We'll move to the next session. To present on the anchoring DMARDS, the Methotrexate, I request Dr. Dharmanand to come and take over. Dr. Dharmanand is a very well-known and senior rheumatologist. He graduated from Madurai Medical College and MD in clinical medicine from Mysore Medical College, and subsequently DM in rheumatology from Madras Medical College. He is the former Secretary General of Indian Rheumatology Association, currently the Vice President of Indian Rheumatology Association and President of Karnataka Chapter Indian Rheumatology Association, and Director and Senior Consultant Rheumatologist at Sakra World Hospital, Bangalore.
Thank you, Chairperson, and my sincere thanks to Dr. Chandrasekhar and his team for the invitation. It's good to follow Dr. Chandrasekhar, and I had always followed him into rheumatology after my MDA. Chandrasekhar was always a rheumatologist and immunologist when we were classmates during MD days, and I thought I would become a cardiologist. So somehow I followed Chandrasekhar into rheumatology and also followed him to his hometown Bangalore. Though I did my schoolings, everything in Tamil Nadu. Initially I thought I would settle down in Chennai, but I followed him to Bangalore with good results. And Methotrexate, Chandrasekhar has alluded to, and as Professor Gauri Shankar has told, was a proud discovery of an Indian chemist or biochemist, Subbarao from Andhra Pradesh, who discovered it in United States. And it was he supplied the first batch of Methotrexate to one of the pediatric hospitals for treatment of leukemia, Methotrexate. So the story of Methotrexate began with an Indian, so we should be proud of this drug. And it is a drug of choice, as you all know, in rheumatoid arthritis. And it is also a very useful drug in many other rheumatic diseases. For example, juvenile idiopathic arthritis is a drug of choice, and it is a drug of almost first choice in dermatomyositis. It is used in arthritis of lupus, Sjogren syndrome, and scleroderma. It is also useful in sarcoidosis, autoimmune uveitis. So it is difficult to imagine a rheumatology prescription without Methotrexate, except for few diseases where it is not that useful. It is also useful in vasculitis, in some of the vasculitis as a second line drug. And the current generation of rheumatologists would not imagine a field without Methotrexate. Though when we joined, Methotrexate was still a second line drug, and people were more using NSAID and steroid. Gold was the original darling of rheumatologists from 1950s to say 70s and 80s. And when we joined DM, there were still patients in our institutions who were still receiving weekly gold and monthly gold. I have administered gold to many patients, and we have done the test dose. Now, we have not used gold since last 20 odd years. So if I have forgotten how to use gold now. This slide is just to stress that inflammation in rheumatoid arthritis is immune inflammation. So we need a solution which deals with this. The another tenet is inflammation multiplied by time is equal to damage, and damage is permanent. This is true for all autoimmune diseases or all inflammatory diseases. So we need to address this point. So earlier we intervene, the more likely that we get good results. With the remission which Chandrasekhar was talking about can be achieved only if we attack these autoimmune diseases early in the course of disease. What were the treatments available? Non-steroidals, steroids have been used less and less in rheumatoid arthritis. They are still useful in many other diseases like ankylosing spondylitis. NSAIDs are still drug of choice, but in rheumatoid they are not drug of choice anymore. DMARDS are the drug of choice. And Chandrasekhar ran through the history. First drug to be used in rheumatology was just 110, 115 years old. 1897, aspirin was synthesized. Then subsequently, gold salts came in 1920s. Steroid came in 1949-50. Prednisolone was introduced in 1955 as a hydrocortisone variant. Lot of non-steroidals came up as a better aspirins in 60s and 70s. Penicillamine was introduced in 70s. Interleukins were identified for the first time in 70s. DR4 as a genetic marker was found in 1977. The period between 84 and 98 was the crucial period in rheumatology. This is where we, in the later part of it, we enter into rheumatology. Oral gold, methotrexate, azathioprine, cyclosporine, sulfasalazine, leflunomide, all these drugs were introduced in this period. And Chanchakra has spoken about inverting the pyramid. And in the late 90s and early 2000s, biologicals have started coming. So, as you all know, methotrexate is the anchor drug in the treatment of rheumatoid arthritis. Other drugs are considered only if the patient is not found to be suitable for methotrexate. A few examples could be patient who has got a renal failure, somebody who is a heavy alcoholic or already have a liver problem, or who would not tolerate methotrexate for some reason or other. There are few people who can't even see the sight of methotrexate can cause vomiting. This kind of patients sometimes we can't use methotrexate. Otherwise, methotrexate is a drug of first choice and is the anchor drug, sheet anchor drug. This drug should be there in almost all rheumatoid arthritis patient. You can add anything, delete anything else. The alternate anchor drugs could be sulfasalazine, leflunomide. And the approach were already step down, step up, sawtooth were already discussed. So methotrexate, what is methotrexate? It is a folic acid analog. It is made, it's a designer drug. They knew that folic acid is important for the production of purines and pyrimidines, and they wanted a antagonist. So this is methotrexate is it competitively works again with folic acid and targets the same enzymes, like it blocks tetrahydrofolate and reduces the production of folic acid derivatives, which are important in the production of DNA. So it is a folate antimetabolite. It has got immunomodulatory effects and also has anti-proliferative effects. I want to stress here that low dose methotrexate is a immunomodulating drug. It is not an anti-cancer drug. High dose methotrexate is an anti-cancer drug. Almost all of us remember methotrexate from our good old Goodman, Gilman or Satoskar, whichever book you have read, as an anti-cancer drug. This is the one which is carried by all of us, unless you become a rheumatologist or a dermatologist, into our memory bank. So when you see a prescription from a rheumatologist with methotrexate, the alarm bell, oh, you are getting an anti-cancer drug. It is to stress here that low dose methotrexate is not an anti-cancer drug. The dose used in rheumatology is anywhere between 5 to 25 milligram, but in cancer it is almost 20 to 30, 40, 50 times higher, 500 milligram and above, if you compare. So it's a totally different, you can say it's a different drug. The beauty of methotrexate is, though it is called slow acting anti-rheumatic drug, this is the fastest of the slow acting anti-rheumatic drugs. It starts working within 4 to 6 weeks, and it is fairly well tolerated, and it combines well with many other DMARDs. So it can remain a sheet anchor DMARDs, and it has got a proven efficacy and safety. So mechanism of action is, it's a folate antagonistic drug. It inhibits purine pyrimidine synthesis. This is the basis of anti-proliferative effects. Some of the side effects which occur in methotrexate is due to its anti-proliferative effects, because the rapidly dividing cells can be inhibited by these drugs, oral ulcers, and this kind of side effects are much more, the gastrointestinal side effects are much more likely to be due to this mechanism of action. But the immunomodulatory effect of methotrexate is more likely to be due to increase in adenosine synthesis through ICAR inhibition. So adenosine is an immunosuppressive or immunomodulating agent, and this explains many of the actions of methotrexate. It is also elegantly proved caffeine is a adenosine inhibitor. So drinking too much of coffee, or if the mice or any experimental animal is given caffeine, caffeine can sometimes block the action of methotrexate. So this could be a practical tip. Somebody who drinks loads and loads of coffee could be advised against taking this. And this is considered now as the main mechanism of action rather than the folate inhibition mechanism. How do we give methotrexate? It is generally started as a 7.5 milligram, 10 milligram or 15 milligram. So initially people used to start with 2.5 milligram, 5 milligram, 7.5 milligram. We used to start with 1996, 97, we used to start at 7.5 milligram and gradually go up. Now the recommendation itself says that you can start at 15 milligram. So the benchmark is going up. Confidence of rheumatologists in using this drug has gone up. So earlier we were scared to use 7.5 milligram. Now we boldly start many patients on 15 milligram. But most of the rheumatologists whom I have seen experience would start somewhere close to 10 milligram and quickly go up by 5 milligram every month to a maximum of 25 to 30 milligram once a week. And please note here that it is given once a week. This could be a source of a prescription error or comprehension error. Many a times in a hurry, methotrexate 7.5 milligram 001, if you have forgotten to write that once a week, the patient can take it every day. Or you write once a week there, or you write Sunday only, and the patients are used to taking medicines daily. They take hydroxychloroquine daily, they take leflunomide daily, they take sulfasalazine, everything daily. So they might take this daily, and this could be a source of a prescription error or a comprehension error. We have to be doubly sure that the patient has understood that this drug has to be taken once a week, because we have seen near fatal and sometimes occasionally fatal side effects because of patient taking 15 milligram of methotrexate daily for 15 days. They come back with severe oral ulcers, diarrheas, pancytopenias. Sometimes they don't respond. They might succumb to a opportunistic infection. And if the patient doesn't respond to a dose above 15 milligram, 20 milligram, you can try to switch over to parenteral methotrexate, because the bioavailability of methotrexate above 15 milligram in a oral dose may not be adequate, because it is absorbed by a protein, it carried by a protein into the system, blood system. The supply of that protein is limited. So it is dose dependent absorption. So 15 milligram above, patients may not absorb well. So switching over to parenteral route or splitting into two equal divided doses could compensate for this lack of bioavailability. Either you can give 7.5 in the morning, 7.5 in the evening. So that would, patients are more likely to get 15 rather than 15 at a single point of time. But there is a huge variability. There are patients who absorb well at even at 20 milligrams. So if the patient don't respond at 20 milligram single dose, I try to split it to 10 and 10. Sometimes they do well. So we need to see the patient every month initially at least, because we need to escalate the dose. Start at 7.5, 10, 15, 20, 25. Within 3 to 4 months we should reach the ideal dose. If you start at 15, within 3 months you should be close to 25 if the patient tolerates it. Higher the dose, the better the response. So how do we give methotrexate? Either we can give it as a monotherapy. Methotrexate is probably the most effective monotherapy. It is at a weight, and if you compare biologicals with methotrexate, they are equally effective as a monotherapy. So 30 to 40% of the patients do very well with methotrexate alone. So it is always worth trying methotrexate in a patient with moderate disease activity as a single DMARD, and they do well. They don't get exposed to too many drugs. If they don't do well, you can quickly add another drug. Patients who have a very high disease activity index are patients who are chronic disease, who have arthritis for more than a year. That is called established rheumatoid arthritis. As the disease duration increases, the immune inflammation gets more and more mature and more ingrained into the body, is difficult to eradicate. So you need more drugs to treat an established disease. And early disease you can always try with a single DMARDs. The most commonly used combination DMARD is methotrexate and hydroxychloroquine combination, which most of us use. It's called double therapy. Methotrexate, hydroxychloroquine can be combined with sulfasalazine. This is called triple DMARDs. And there are various other combinations like methotrexate and sulfasalazine, methotrexate plus leflunomide, which is a potent combination. Potent combination both efficacy wise and also more likely to produce side effects, because the side effect profile of leflunomide and methotrexate are very similar. Methotrexate and cyclosporine, methotrexate and tacrolimus also are effective combinations. And methotrexate, of course, can be combined with almost all the biologicals, and it works better. Even the biologicals work better if it is combined with methotrexate. So it is a good anchor drug on which you can add any of the available DMARDs for a better efficacy. How long we should give methotrexate? This is a question asked by the patients. It's a difficult question to answer. Probably long term, definitely sometimes lifelong, but definitely long term. And the dose can be reduced. If somebody is doing very well at a dose, somebody is doing very well at 25 milligram, I'll keep the same dosage for at least a year, then start dipping down a little bit. Again, that reduced dose, again continue for 6 months to 1 year, again dip down. In that way, we can avoid a sudden flare. 25 go down to 7.5, again vicious flares, again you go up and come down and require steroids to manage the flares. So you can avoid all that things by going little slow. How do we know that methotrexate is a good drug? See, if you read the literature, methotrexate's efficacy is same as of that of sulfasalazine, as that of oral gold, as that of leflunomide, many other drugs. But we feel that methotrexate is a better drug because the trials are of short duration, 1 year, 6 months duration. If you compare 1 year, 2 years data, methotrexate and sulfasalazine seem to be the same. And also the dose they have compared was 10 milligram and 7.5 milligram of methotrexate with full dose of leflunomide and full dose of sulfasalazine. So it is not a fair comparison. But the proof that methotrexate works better than the other is the length of time the patient continues, or otherwise called survival of a DMARD. If I start a patient on methotrexate today, what is the chance of him continuing the methotrexate 5 years? This is the highest for methotrexate. Even in this state, almost at the end of 120 weeks, majority of the patients, 40 to 50% of the patients are continuing to take methotrexate. This is the proof that this drug is effective and also reasonably safe. So if a patient is able to sustain the drug for 20 years, 15 years, we know that the drug is effective. If the drug is not effective, the patient would have stopped himself or we would stop. And the drug causes a lot of side effects, also the drug would go out. So the very fact that the drug is continued for many years vis-a-vis other DMARDs is a proof that this has got a much more potent drug and the potency is sustained over time. So we can now, the recent data, because compared to earlier data, we somehow, because the drug is very effective, we persuade our patients to tolerate minor side effects. We are not going to stop this drug for somebody who complains of minor nausea and occasional diarrhea. So we insist that patients should take this drug. Now more than 50% of patients are taking it beyond 10 years. So this is a good proof that the drug is effective and also reasonably safe. When I said that it is safe, but it does have a lot of side effects, nausea, vomiting, dyspepsia, flu-like illness are not uncommon. At least 10 to 15% of the patients complain of little bit of nausea, vomiting on the day of methotrexate. Many of them are willing to take these side effects because the drug, they perceive that drug is effective. Okay, doctor, one day I will somehow manage, so I will take it on a Saturday so that I am at Sunday. There are lot of people, Sunday I want to be alert with my family, so I will take it on a work day. My husband and children are at home, at office and school, so I can sleep at home. So people can tolerate this. These side effects are probably due to adenosine release. The adenosine, which is the reason for its effectiveness, can also cause these symptoms. Oral ulcers, hair fall, bone marrow toxicity, diarrheas are more likely to be due to antifolate mechanism of action. And it is also a potential liver toxin, and transaminitis is very common. A mild transaminitis is not a serious problem. Sometimes we can, as we continue methotrexate, the transaminitis automatically settles down. It itself can cause or contribute to NASH, again through adenosine mechanism, and in India we are all supposed to have a higher incidence of fatty liver or non-alcoholic steatohepatosis. This could be a problem in many methotrexate patients. Continuation at an optimal dose. So sometimes because of the liver transaminitis, persistent transaminitis, we end up giving a suboptimal dose, thereby compromising the efficacy and effectiveness of this drug. So it is essential for us to advise patients to stay away from alcohol, reduce weight, and remain fit, so that fatty liver comes down, so that methotrexate can be given at a higher dose. And cirrhosis is a rare combination when given in rheumatoid arthritis, but patients with psoriasis and psoriatic arthritis could be slightly different genetically, because cirrhosis seems to be slightly higher in these patients. So if I give methotrexate to a patient with to rheumatoid arthritis, we are not too worried about cirrhosis as a complication. But when we give the methotrexate to a patient with psoriatic arthritis, I would be much more vigilant in monitoring the liver function tests. And pulmonary toxicity is very rare. So how do we monitor? We need baseline test. Before starting methotrexate, we should have a complete blood count to make sure that marrow is fine. Complete liver function test, look at SGO-SGPT, and also look at the albumin levels. Creatinine is very essential, because renal failure is a potential contraindication for methotrexate usage, and side effects of methotrexate, all the side effects are higher if the creatinine levels are higher. And baseline hepatitis B and hepatitis C screening is a must, and a chest x-ray just to make sure that we need a baseline chest x-ray. Tomorrow patient comes with a cough after starting methotrexate, you would like something to compare, so baseline chest x-ray is essential. Initially monitor every 2 to 4 weeks, complete blood count and an ALT and AST. Then if it is stable, once the stable dose is reached, then you can do the same test every 3 monthly. At least once in 6 to 12 months do a creatinine. Many times physicians forget creatinine because we think that it's not a renal toxicity. But patients may have a comorbidity like diabetes, hypertension, and they may develop UTIs, sometimes they develop sepsis. All these things can increase the creatinine a little bit. 1.1 could become 1.3, 1.3 could become 1.6. When it goes there, your creatinine clearance progressively comes down exponentially compared to the 1 point going up in the creatinine value. And this can lead to methotrexate toxicity. 10-15 milligram very well tolerated at 0.9, 15 milligram may not be very well tolerated at 1.6 creatinine. So we have to be vigilant about the renal functions as well. How do we, if somebody has a side effects and we still want to give methotrexate because that's still the best drug. So what are the strategies to reduce the methotrexate side effect or increase the chance of methotrexate being retained as a DMARD? Folic acid is the cheapest and simplest method. We can give up to 5 to 20 milligram once a week. There's a controversial lesser amount, 5 milligram once a week may be better than 20 milligram once a week, because too much of folic acid sometimes can theoretically reduce the efficacy of methotrexate, though most authorities agree that methotrexate can be given, folic acid can be given up to 20 milligram without significant reduction of efficacy. Another option, somebody complains of dyspepsia, not tolerating the drug, we can try to give the drug with a parenteral dose. If the dyspepsia is due to local irritation of the GI tract, some of the patients tolerate parenteral drug much better. And sometimes splitting the dose. Some patients have a problem with a single large dose. 25 milligram bedtime, next day morning they vomiting, they don't feel like eating, they feel very sick. So splitting it into equal to divided by 12.5 in the morning, 12.5 in the evening within 24 hours. increases the bioavailability, and also may reduce some of the dyspepsias patients complain. We can also use antiemetics like granisetron and domperidone to reduce the nausea. There are few interesting papers using acupressure to reduce nausea of anti-metabolites and anti-chemotherapy. Simple, have a 3-finger breath, just give a pressure to this. It is supposed to be acupressure vomiting point. So if you give a pressure to this area, 3 fingers from your distal palmar grease, give a pressure to this area, is supposed to reduce the nausea feeling. I tried it sometimes during traveling sickness. It seemed to work. And be aware of other liver toxins. When we give drugs to patients with rheumatoid arthritis, the moment we see an elevated liver, we always think that it is methotrexate. But many times it is the NSAID which is given, or the antibiotic which was given the previous week for some dental infection, which is the cause for liver enzyme rise rather than the methotrexate alone, or a couple of pegs he has had the 3 days before. So look at all the other risk factors for liver toxicity and take that out. Methotrexate can be continued. Weight reduction is a useful measure to reduce NASH, and if the patient is doing well, reducing the dose can help the patient to continue methotrexate and retain the remission. What are the challenges as a rheumatologist face when it comes to methotrexate? How to convince methotrexate is superior to other DMARDs, though most people would think that when I read the literature it is equal efficacy. I have tried to prove that point, that it is a drug better retained on the long term, and it is definitely seen to be superior to the other DMARDs. And to convince the population, because the moment we give methotrexate, if they go into an internet and see any web page, all the side effects which were described are all due to described in oncology literature. That gets highlighted. To convince the patient that low dose methotrexate is not the same as high dose methotrexate is a challenge. And websites highlight the side effects of the drug rather than the side effects of the disease. When the disease can cause a lot of problems, which can cripple a person and it can change the quality of life, and some amount of risk, some amount of side effects could be the risk is worth taking there, because the side effects can be monitored and modified, but disease, if not treated, gets into a definite decline. So this is one challenge, because the moment we give they go into website, they download so many things and come back to us, so no, you have given us a very toxic drug, doctor. So we have to, this is a challenge we face. And also the discrepancies, how to address. Even our own doctors, many meetings, some of the physicians and JPs get up and talk. No, Goodman-Gilman says this. Because sometimes the authors have not changed. They have just cut and pasted the same articles which were written 10 years, 15 years back. Some of the basic textbooks which we read as basic MBBS doctors, physicians, have not changed. Many old textbooks which are not revised still say that salicylate is the drug of choice. NSAID is a drug of choice in rheumatoid arthritis. Rheumatoid arthritis is a benign disease. When this is not, patient don't respond to this drug, more toxic drugs are introduced. These words are still used in primary care textbooks. This discrepancy between what is known in the current rheumatology literature and what is still written in books directed towards a general practitioners or a physicians or a pharmacologist is still there. So how to address this? This is an issue which as a rheumatologist we face. To conclude, methotrexate is the anchor drug, is the current gold standard against which all other drugs are tested. If a new drug is going to come to the market, it would be tested against methotrexate. So the methotrexate is a benchmark, and it is the current gold darling of our rheumatologists. It is suitable for early treatment strategies. It works well as a monotherapy in 30 to 40% of the patients. It combines very well with many other DMARDs. It has an acceptable safety profile. When I say acceptable, it has to be monitored, but it has got a very acceptable safety profile. Low dose methotrexate has to be differentiated from high dose methotrexate, which is an oncological drug. And monitoring regularly improves the safety of the drug. Thank you very much for patient hearing. Any questions?
Dr. Mahindra, answer.
Thanks, Dharmanand. Several cohorts have shown that cardiovascular reduction, mortality reduction is less on people, rheumatoid arthritis patients who are on methotrexate. I think it's going to be a major study in America. CERT, I think it's reduction of cardiac inflammation in patients, normal patients, not the rheumatoid arthritis. Is methotrexate going to be the new statin?
I'd be excited to if it happens, but it's very unlikely. But in rheumatoid arthritis, couple of ways methotrexate can be very effective in preventing cardiovascular morbidity. One is inflammation itself is a risk factor for accelerated atherosclerosis. By methotrexate being an effective anti-inflammatory drugs, it reducing the autoimmune inflammatory burden can reduce the risk of accelerated atherosclerosis. That is one mechanism. Second mechanism is adenosine. So dipyridamole is an anti-platelet effect of dipyridamole is due to adenosine release. So methotrexate may have some potentially anti-platelet effects as well. So that is one way of looking at it being protective against cardiovascular mortality. There are data, people who have used methotrexate, anti-TNF, having less cardiovascular morbidity. So definitely in rheumatology, rheumatoid arthritis patient is going to help. Whether it will become next statin is difficult to say, sir.
When choosing patients on methotrexate, I think these transaminase elevations are much more common in, as you said, obese and people with metabolic syndrome. Can we probably be more careful in dosage while choosing this patient? Will it help? And I personally think I won't worry until unless the liver function test go up to 2.5 times beyond that. The normal range is 30. I won't worry until unless it crosses 100. Do you have the same?
Yes, sir.
Yeah.
Say even the recommendation is if the LFT is more than 2.5 times more than the baseline, then we have to either temporarily withhold or reduce the dose. So a transient elevation of liver enzymes should not lead to immediate de-escalation of DMARD treatment. So if the liver enzyme, the baseline is say 25, if it has gone to 40 or 50, I would continue methotrexate, continue to watch. If it keeps on going up, definitely we would again sit back and think whether look for other causes. I look for whether he's taking any other drug which can cause liver function elevation. The commonest would be NSAID, and diclofenac is notorious to cause liver function enzymes going up, liver enzymes going up. And I look at his alcohol, his or her, there's a lot of hers are now taking alcohol. So I look at their alcohol intake and also look at the other drugs they are using. See, we think that all side effects, almost all physicians think that if somebody is on 20 drugs, think that only methotrexate is the one causing side effects. Sometimes side effects could be due to the BP tablets they are taking, could be due to the diabetic tablets they are taking, and many other tablets, anti-epileptic, anything can cause liver enzyme to go. Alternative medicine. I'll look at their, I'll ask whether they are taking something on the recommendation of their neighbor. They are also taking some churunas and other stuff. So all these things we need to look at before I attribute this to methotrexate, because I don't want to lose this methotrexate, because this is still the best drug. I'll try to retain as much as possible, look at the other possibilities, and if I can eliminate some of them, then methotrexate could be continued much more safely.
If the patient is on leflunomide and methotrexate and liver enzymes goes up, which one to down titrate?
It depends. If somebody was on a stable dose of methotrexate, was doing well with regards to liver, and I have introduced leflunomide, and the liver end starts going up, then you would probably come down on leflunomide and watch. Then probably we have to withdraw, either reduce the dose of either, and then again step up the one and see. See, many times a transient elevation settles down over time. For some reason, it settles down. It doesn't seem to lead to a progressive liver damage in majority of the patients with rheumatoid arthritis. To temporarily go down, allow the liver to recover and slowly go up. Many times we are able to continue that.
In the second session, in the post-lunch session, we have a long discussion on how to handle those liver enzymes.
Thank you very much, Dr. Dr. Dharmanand, sir. If people have more questions, I would appreciate it if you could keep it to the
1 minute.
tea break.
Please. Honorable Speaker, this methotrexate inhibits the dihydrofolate reductase and formation of thymidine phosphate. It is supposed to involve the DNA synthesis, and probably it also produces death of the cells. That is the point, especially in malignancy, etc. No, same effect can it have on the pancreas? Can the incidence of diabetes has been reported or seen or experienced, whatever it may be? Because when it is entering into the cell, it can damage the liver, and why not the pancreas is one point. Secondly, pregnancy. What about pregnancy? Can we use it is another point to be thought of in this particular case.
The second question first, it is contraindicated in pregnancy. There is definite increase in risk of abortions and teratogenicity when patients are exposed pre-conceptionally or at the time of conception. The maximum risk is around the first trimester. So it is generally contraindicated during pregnancy and lactation. Number two, whether it can damage the pancreas, no. The anti-proliferative effects occur more in rapidly dividing cells. The rapid dividing cells are hematopoietic cells and gastrointestinal tract, oral mucosa. These are the tissues which are more likely to be affected. Stable tissues like liver and pancreas are not affected by the anti-proliferative or anti-folic acid metabolism effect. And liver toxicity is not due to direct cell death. Liver toxicity is more due to maybe adenosine release and various other mechanisms which I can't tell now at this moment.
Thank you very much. You have become my teacher now. Thank you.